Summary of Shapiro's adaptive information processing model, which he has put forward. It's very interesting, actually. EMDR started off being a therapy strategy that people would use in the context of treating trauma. EMDR has evolved over time, and Shapiro, about a year ago, started encouraging people to refer to EMDR therapy just in the same way as we refer to cognitive behaviour therapy or cognitive behaviour therapy or emotion-focused therapy. And she says, no, we have a framework here that is the basis for a totally different approach to psychotherapy itself. So there are some people like Bethel van der Kolk who still argue that EMDR is just a technique, and yet there are a large number of people saying no, EMDR can be considered an approach to psychotherapy in itself, and it has a foundation to it. And so, these are some of the basic tenets of her adaptive information processing model, which curiously has attracted absolutely no attention whatsoever outside the world of EMDR. No one outside the world of EMDR is even aware of AIP, which is another commentary on the politics of psychotherapy, I suppose. She basically says, well, we all have an adaptive information processing system in our heads there, which is intrinsic, it's organically based, and it helps people move towards adaptive resolution, because we know the vast majority of people who get exposed to a traumatic event don't go on to develop PTSD. There's something in us that allows the majority of us to actually resolve these things quite spontaneously. So, this natural information processing system is geared to integrate these experiences. Memories are stored in an associative network, and these are the basis of perception, behaviour, and so forth. So this notion of memory networks that we've described as a vast collection of connected ping pong balls, we live in the midst of that, and through that bubble of ping pong balls, we perceive the world in a certain way, we make sense of it in a certain way, we respond behaviourally, emotionally in certain ways. Experiences translated into physically stored memories. Donald Hebb, back in the 1950s, was talking about cell assemblies. We had no idea, we didn't even know what neurons looked like in those days. And so, how are things stored? If I say this, Mary had a little, how did you do that? What went on in your head that allowed the word lamb to pop up? We don't really know. And then if I say to you, yes, do you remember those advertisements that the landlord put on? Mary gave up a date with Tom Cruise because Mum was cooking a delicious roast of... Of course, Mary had a little lamb in a different context. Have we got any New Zealanders in the audience? Okay, I'm actually a New Zealander myself. I'm asking to say 6 pieces of fish and chips quickly, and you'll guess it. Well, there are jokes in New Zealand about what New Zealanders do with sheep. So when you think about Mary having a little lamb, I'm sorry, I've just put something into your memory that you will find indelible, although we may be able to treat you if you're sufficiently troubled. Okay, so she's saying that yes, these memories are stored at some level. So if I ask you over the next few days, what did Mary do with that lamb? Then, this is a projective test, you see. If you say she had a nice meal, that's one thing, or if you blush and avert your gaze, I know you're thinking about some of the other things that Mary might have done with that lamb. So Mary having a little lamb, I'm sorry, I just ruined it for you. Because that is somehow in there. And of course, people often say to me, they come in and say, I want to get rid of my memories, I want to get rid of this stuff. Well, there are very few ways of doing that. One of the more reliable ones is to have a stroke, but that's not to be recommended. That's true, isn't it? The trouble is you get rid of a lot of other good stuff as well. Stored memory experiences that contributors to the pathology into health. So we will hopefully have memory networks that say, I'm lovable, I belong, the world's a reasonable place, and so forth, and those are all good, healthy schemas to have. And yet many of our clients have experiences that tell them quite the reverse. Trauma causes a disruption of normal adaptive information processing, results in unprocessed information being dysfunctionally held in memory units. We know something about that process. Bessel van der Kolk, many years ago, set out some of the basic neurophysiology of what's involved with, when trauma comes into your experience. Now, trauma in the world of EMDR obviously includes EMDR criterion A events, but also those events like my detective senior sergeant of neglect, of abuse, of experiences of being unwanted or devalued, and so on and so forth. So the brain makes no distinction between big T and little T traumas. The brain hasn't read DSM. Neurologically, they're encoded in much the same sorts of way. Your experience linked into previously stored memories. I think this takes us right back to some of the basics of Piaget. And you remember some of the process of assimilation and accommodation by which we make sense of new experiences. And if events come into your life which are outside your cognitive map of the world, then they're not going to be well integrated. If experiences are accompanied by high levels of dissonance, they may be stored in implicit non-collective memory systems. They contain the perspective, affects, and sensations of the event, stored in a way that doesn't allow them to connect with adaptive information. So come back to our metaphor of ping pong balls. Here we have some clusters of ping pong balls which are not well integrated with others, and some of them in fact are living in those locked doors in the basement. And so our task is to recognise that there are such experiences. My phone's vibrating madly, but we'll just ignore that. So our task is to look amongst the memory networks for the obvious gaps, which indicate there are ping pong balls that are tucked away in the basement behind locked doors, but also to explore some of the other sort of hot memories that constitute the essence of a dysfunctional network. So with my detective senior sergeant, we spent a couple of sessions exploring a range of experiences from the earliest to the most recent, where she was treated badly simply because of her gender. And those discrete memories that had a time and a place, they were the target memories that we would use, and we would use those in any emotion-focused therapy. If you don't do EMDR, you could do, probably the most obvious one would be imagery rescripting as an approach to process that. Adaptive information resources and memories are also stored in memory networks. Okay, let's think about this a little more closely. Let's say that big circle on your piece of paper represents the memory of your traumatic event. And I'm asking you, how would you like to think when you're over this? So if that meaning in that box is I'm not safe, then there's a little arrow out to some experience that says I'm safe now. Or if the dominant theme in that central circle is I'm unlovable, you're looking for some experience where a person has some sense of being valued or loved or appreciated. And so what we're looking for is in the positive belief that we elicit in the EMDR, we're looking for experiences that allow that to be so. When Shapiro asked her clients, how true does that idea, I'm safe, feel when you think about that memory? And they said, about halfway true. That tells us that there are experiences in that person's memory networks that allow that to be somewhat true. So, going beyond the basic EMDR protocol, the therapist might say, tell me about some of those experiences where you've actually felt safe or you felt loved or belonged. And you're tapping into positive resources which constitute the information that you want to link with the more maladaptively stored information. Okay. Direct processing of unprocessed information or unresolved memories, facilitates linkage to adaptive memory networks. So a person can now think about themselves in a more adaptive way. Non-adaptive perceptions, affects and sensations are discarded. As processing occurs, there's a hypothesized shift from implicit non-declarative memory to more explicit declarative memory, from episodic to semantic. Okay, so the processing of this memory causes that shift in all those components. So getting back to the ABC clip we started with, what happens to the memory when we're done? It's more distant, it's desensitized, I can think about it more adaptively. That's the essence of what this is about. So the clinical implications of this model are very simply clinical complaints that aren't organically based are caused by insufficient information, that aren't organically based or caused by insufficient information, are viewed as stemming from maladaptively stored and unprocessed or unresolved information. Remember, information is content, meaning, and affect. So that circle that you've got, it's a bubble of information. And that bubble has not been able to link naturally with more adaptive information. Okay, I'll just skip to the bottom for the rest of the time. The information processing system, those stored associated memories, are the primary focus of treatment. Okay, there's a lot there. Let's just pick up the key points. The second point, the intrinsic information processing system, the client's own associated memory networks, are the most effective and efficient means to achieve optimal clinical effects. The implication of this is that once you start processing the memory in EMDR, so let's just go over that carefully. We say, bring to mind the memory of that time when you were pinned against the wall, thinking of the idea that you're not safe now, and just noticing that fear in your chest. We've now got an activated memory, and now we add the argument component. Shapiro says, at that point, your task as a therapist is to stay out of the way. So when the client makes some report at the end of a set of eye movements, typically 30 seconds, that says, I'm having trouble remembering it, or I was thinking of some other memory, or whatever. Unlike other therapies, the therapist does not stop and engage the client in verbally processing that report. And that's one of the hardest things for therapists in learning EMDR, learning to sit on their hands, as it were, and stay out of the way and trust that the process will unfold. Now, there are times when there is a need for some more active therapist intervention, something that Shapiro calls a cognitive interweave. By the way, if you ever read some of Shapiro's works, do keep in mind that she was an English lit student to start with, and there is a certain literary turn of phrase in some of her expressions which you will find in no other psychological books. So there is a little bit of Francinese in some of the writings on EMDR. Unimpeded processing allows the full range of associations to be made through the targeted memory and the larger integrated networks. Again, unimpeded means unimpeded by the therapist's good intentions to intervene. And so this is and I was even in doing EMDR trainings, people love to reflect and paraphrase. When new memories come up, clients naturally want to say, oh, that's interesting, tell me more about that. And those are all the things that they get a slap on the wrist for in EMDR training. Because that's the things that we're trying to not do. Now, Shapiro goes a little further and she says all therapist interventions are viewed as distortions. And the reason that we don't teach the more subtle variant of EMDR where therapists actually introduce material is because if you did that straight away, all therapists would do would be to continue doing the normal talking therapy and wave their fingers at the same time, and that's not EMDR. Processing shifts all elements to adaptive resolution, which we have defined. Okay, so let me just walk you through very quickly the basic phases of the EMDR. And the first phase is of the eye movement part of the EMDR only occurs during 2 phases, and the assessment and preparation, particularly for more complex clients, is essential. My young lady who curls up in the little ball, we didn't get to do any trauma work until we got to about the 18-month stage, when she could sit in the room without dissociating, when she could tolerate some exposure to disturbing content. Then we were ready to do some trauma therapy, but it took us a long time to get there. Okay, so the first question is the client suitable for EMDR? Do they have that requisite stability? Do they have the capacity and the willingness to sit with unwelcome private experience? There's an element of mindfulness in EMDR which is understated in the EMDR literature. Essentially what we are asking people to do, we're asking people to sit with unwelcome private experience. The very experience that they've spent a lifetime trying not to have. So clearly preparation is necessary. Obviously, this next week is EMDR appropriate with the client. I over the years have met a lot of people who've learned EMDR and enthusiastically think that it's all about the finger waggling and want to do it with everybody. So they say, I'm going to do EMDR with my next client. That's the very last thing they should be thinking. The first thing they should be thinking is, what's the presenting problem? What's the history of the client that's brought them to this point? What are the goals of therapy? What are the obstacles to address in therapy? And how will I address those obstacles? That last question, the answer might be, I might include EMDR in my treatment plan, rather than think of the EMDR as the be-all and the answer to everything, and it's not. Clearly, we have to do a trauma history. We have to also pay, with more complex clients, close attention to aspects of developmental and attachment history as well. The DES is widely used as a screening tool. Francis Shapiro tells the chilling story of being halfway through a session and all of a sudden the client's state changes. He's obviously working with someone with undiagnosed dissociative identity disorder, and there's another ego state suddenly comes in the room with a totally different set of memory networks, emotional responses and meanings. So it's almost like you've got multiple clients in the room and you're not quite sure if they know each other. This audience will be familiar with that, but I would seek to actively discourage therapists learning EMDR to step into dissociative disorder. They'll simply do some damage. You need considerable skills under your belt, and skills that aren't, that come from beyond the field of EMDR. So obviously the capacity for emotional regulation and distress tolerance needs to be assessed. The therapy relationship is so important. We're asking, the therapy relationship has received a lot of attention in recent times, but this is the vehicle, this is the space that carries the work. And so unless the client is comfortable with you and feels safe and can trust you, and this is what my young lady was learning over many months. She was slowly learning that she could trust to sit in this room with an older man. And that was valuable, and had we attempted to do EMDR prematurely, we would have simply added therapy to the list of traumas which she would have avoided for the rest of her life. It is easy in trauma therapy to do harm. There is no doubt about that. The literature is replete with examples of casualties of enthusiastic therapists rushing in prematurely because they've learned this new toy trick. And EMDR is probably one of the worst of these things because it's so weird when you want to try it. You need to explain EMDR, you need to give people a way of stopping the process. We're asking clients to be a mindful observer, so there is a mindfulness component. The preparation of clients, for some of my clients, my chap who's pinned against the wall, it took me 5 minutes to figure out a safe place with him. With my lady who curls up in a little wall, it took us months. And so, that is absolutely essential. The target memory is what we're looking for. This is getting back to your little circle on your piece of paper. This is the memory and the meaning and the affect. We elicit negative and positive beliefs and the believability of that. I've spoken about that earlier. So there are 7 components to target assessment, and this is the bit that therapists find hardest to learn actually. The hardest part to figure out with EMDR is figuring out what the appropriate negative and positive beliefs are. Because they are not that simple at times. The desensitisation itself, a set of eye movements lasts about 30 seconds. The standard instructions for clients is just to observe, just to notice, just to be aware of what your experience is. There are subtle variations. And the standard probe I've already mentioned. What do you notice now? Clients report what they notice and you start the next set of eye movements. So you can see from a therapy skill sort of level, this bit's easy. You know, anyone can waggle their fingers. This is not difficult stuff. It's knowing where to go in the memory network and how to prepare the client to tolerate the experience. That's the crucial part of any trauma therapy. Okay, so when we have got a memory that is desensitised to the level of 0, 1, we say we've done desensitisation. We now move to integrate the positive belief. So we check, has that evolved? My client who had that history of double depression, we started off with a positive belief that says I can learn to like parts of me, which is not the perfect expression of mental health by any means. Once we had done some desensitisation around some of the memories, she came up with a much more positive belief. You know, she was able to acknowledge that she had some good parts to her, which was a progression. We again just check how believable that feels. We pair the memory and the positive belief when we do further sets of eye movements, and we continue in that vein, typically until the believability reaches 6 or 7 on the 7-point scale. Typically, the integration phase with simple trauma takes most therapists about 4 or 5 sets of eye movements. The length of time in desensitisation, it can vary considerably. The study that Chris Lee and I published in 2006, which has been widely cited, the average number of sets to desensitisation was 14.86. So we're talking about roughly 7 minutes of active exposure. And that varied considerably from some clients you'd be there in 5 sets at one extreme, and others you might be going on for a whole session and still not quite be desensitised. So it can vary considerably. I love the title of Bessel van der Kolk's book, What He Thinks of Score, because essentially what you're asking people here to do in this short phase of the EMDR is to focus on the now distant memory and the positive belief, to simply scan their body. So they're looking for a somatic confirmation that they are lovable or safe or whatever the positive belief is. That typically takes, most therapists would typically take 30, 45 seconds. And then a thorough debrief. We have dived into the memory network. Are there other memories that are associated with this network? For most of our clients, the answer is yes. Will there be further processing post-session? Almost certainly. Almost certainly. And so it is important to review the experience and let people know what's in score. It's always recommended that the therapist be contactable if needs be. I work predominantly with complex trauma. I would have on average about 2 clients a year phone me between sessions because they're struggling. And that's not a lot compared with the number of clients that I would see in a typical year. So don't get sort of alarmed by the fact that all your clients are going to be pestering you at night. It simply doesn't happen. The reevaluation is what you do next time after the session. Have we got desensitisation? Have we got the integration of the positive belief? And are there other things